Intravenous fluid administration is a critical aspect of perioperative care aimed at maintaining adequate intravascular volume to ensure cardiac output and tissue perfusion. Perioperative fluid administration has two goals: to ensure adequate intravascular volume and to prevent electrolyte and acid-base disturbances. Water constitutes 60% of total body weight, distributed between intracellular fluid, 66%, and extracellular fluid, 33%. The extracellular fluid is further divided into interstitial, 75%, and plasma. Under normal conditions, the intake and output of fluids and electrolytes are balanced. The average daily water intake is about 2,500 milliliters, with output balanced through urine, feces, and insensible lossy. Capillary hydrostatic pressure decreases as plasma oncotic pressure increases. Driving fluid shifts across capillary walls. At the arterial end of capillaries, fluid is pushed out due to high hydrist. In homeostasis, the intracellular osmolarity and extracellular osmolarity are equal. Hydrostatic pressure is the driver of fluid movement. The net force at the arteriolar end of the capillaries pushes. Modified Starling's equation, taking EGL layer into consideration. Lymph plays a major role in returning fluid back into the circulation. The endothelial glycocalyx is a carbohydrate-rich layer on the vascular endothelium that regulates vascular permeability, coagulation, inflammation, and oxidative stress, plays a key role. The oncotic pressure difference is buildup between the adsorbed albumin in the soluble EGL layer, a small protein-free zone, subglycocalyx space, leading to the revised Starling's equation, an illustration of how the human body is divided into fluid compartment. Distribution of various commonly used fluids in different body compartments. Composition of various transcellular fluids you can see on the slide. Distribution and excretion of normal saline and balanced salt solution after intravenous administration and with damaged EGL layer leading to edema formation. Edema is the accumulation of fluid in the interstitium with an increase in interstitial compliance and the role of the glycocalyx in water homeostasis. Protecting strategies include using balanced crystalloids, avoiding hypervolemia, and using specific medications like statins and sevoflurane, statins, nephrine, sulodexide, etanercept, and others. Reasons for infusion are presented on this slide. Fluid status involves a combination of patient history, clinical examination, and various monitoring techniques. Fluid balance charts and laboratory tests all contribute to a comprehensive assessment. Symptoms of dehydration are presented on this slide, and dynamic fluid challenges. There are three main types of intravenous fluids: crystalloids, colloids, and hypertonic solutions. Crystalloids include isotonic, hypotonic, and hypertonic solutions, such as normal saline and glucose solutions. Crystalloids isotonic, hypotonic, and hypertonic with shifting of fluid are presented on this slide. Different types of IV fluids are presented on this slide. Different types of hypertonic solutions are presented on this slide. Hypotonic solution and colloids are presented on this slide. Crystalloids, isotonic indications, are presented on this slide. Isotonic fluids and their uses are presented on this slide. Hypotonic fluids indication, special considerations, and their uses are presented on this slide. Hypertonic fluids indication, special considerations, and their uses are presented on next slide. Result after resuscitation with a solution that has SID less than 40, such as normal saline. Sodium and chlorine content of solutions and solution that has SID less than 40, such as normal saline. Crystalloids with strong ion difference with chloride of 153 mmol L can lead to hyperchloremic metabolic acidosis and damage the EGL and result in acute kidney injury and impaired clotting function. EGL is destroyed by large volume of fluids or hypervolemia. Atrial natriuretic peptide released from the stretching of atria is considered to be one of the triggers for EGL destruction. Colloids may be used in specific cases where rapid volume expansion is needed, but they carry risks of coagulopathy and renal impairment. Colloids may be used in specific cases where rapid volume expansion is needed for their plasma expanders effect, but they carry risks of coagulopathy and renal impairment. Mechanism of action: volume expansion. Large molecules do not easily pass through the vascular walls. Osmotic pressure that draws fluid from the interstitial spaces into the intravascular space. Albumin is very effective at expanding blood volume and maintaining blood pressure. The effects of albumin infusion are rapid, making it useful in emergency situations and prolonged action. Here are some key contraindications. Severe anemia, further dilute low red blood cell count, cardiac failure, pulmonary edema, allergic reactions, hemodilution risk, risk of hypotension with ACEI. What to do if you suspect transfusion reaction, you can see on next slide. Hydroxyethyl starch is a valuable tool in fluid resuscitation and volume expansion. Due to its potential risks, especially related to kidney function and coagulation, its use should be carefully. Precautions: transfusion reaction you can see on next slide. Monitoring and administration vital signs, renal function, coagulation parameters. Precautions: transfusion reaction you can see on next slide. Components of fluid therapy, maintenance therapy, and fluid resuscitation. Maintenance therapy refers to ongoing treatment aimed at sustaining a patient's condition and preventing the recurrence or progression of a disease. How to calculate maintenance fluid therapy you can see on next slide. What is the parameters used to assess volume deficit you can see there. Let's remember how to know if a patient is hypovolemic. Avoiding hypervolemia and ischemia seems to be the best protection of the endothelial glycocalyx and therewith the endothelial barrier, the main idea of this interesting article. Main goal of prevention complications of perioperative infusion therapy is optimization of the target strategy based on monitoring data. Overview of the common sonographic findings in hypovolemia, hypervolemia, and vasodilatory states. These clinical entities are dynamic and can be seen in the same patient during the course therapy. Indications for different methods of perioperative cardiac output assessment you can see there. Checklist for a safe process of fluid de-escalation presented in this article. The dose of diuretics should be adjusted as needed according to achieved fluid removal balance as well as tolerance. There is ongoing debate between liberal and restrictive fluid administration strategies. Recent studies suggest a moderately liberal approach for major surgeries, balancing the risks of hypovolemia. Effective management of hypervolemia involves identifying and addressing the underlying cause, as well as implementing strategies to remove the excess fluid and prevent complications. Drop factors, also known as drip factors, refer to the number of drops, GTT, that make up 1 milliliter of IV fluid. IV tubing sets have different drop factors, which can be either macrodrip or microdrip. The flow rate is typically calculated in milliliters per hour, milliliter per hour, or drops per minute, GTT per minute. Here are the steps and formulas for calculating both types of flow rates. Combining fluids with vasopressors can be more effective in managing hypotension than using fluids alone. Vasopressors help recruit endogenous fluids and maintain arterial pressure, enhancing hemodynamic. Hemodynamic consequences of combining fluids and vasopressors. 10 tips to optimize vasopressors used with hypotension you can see in these interesting article. Crystalloids and colloids can cause dilutional coagulopathy, with synthetic colloids having a greater potential for coagulation impairment due to multiple non-dilutional mechanisms. In humans, a 40% in vitro dilution of whole blood with 0.9% saline results in decreased platelet function as measured by the impact cone and plate analyzer. Synthetic colloids cause a dilutional coagulopathy proportionate to the degree of blood volume expansion and may lead to impairment of coagulation intrinsic platelet dysfunction and others. The natural colloid albumin also has the potential to cause hypocoagulability. The mechanisms may be similar to synthetic colloids. Diagnostic modalities that can detect alterations in coagulation function caused by fluid administration, tests of platelet number and function, tests of plasma coagulation factor function, ViscoLS. Thank you for watching.